Good evening. I'm Dr. Veronica Bloom, and I will be moderating our webinar tonight. Welcome to Supporting the Postpartum Mom. How can I help? The birth of a new baby can be both a joyous and challenging time. This webinar will focus on the signs and symptoms of postpartum depression and perinatal mood and anxiety disorders, as well as tips and resources on how best to support the new mom in your life. Tonight, we will hear from two speakers who have a vast knowledge in the field of postpartum depression, as well as family dynamics and how to support a new mom. Once our speakers have had a chance to discuss the topic, we'll have time for Q&A from our audience. I want to encourage everyone on the webinar tonight to type questions at any time into our Q&A feature on the Zoom call. These questions and answers will help shape our discussion into an even better and more informative evening. So please send your questions directly into the Q&A feature on the Zoom. Our first speaker is John Carr. John is a licensed independent clinical social worker who has a private psychotherapy practice in Needham, Massachusetts. John has spent the last 20 years supporting men and fathers as they grapple with new and expansive ways to be loving and supportive to themselves, their partner, and their children. He is the author of the book, Becoming a Dad, The First 3 Years. Tonight, John will focus on how to support the new mom in your life and ways to help new moms through this challenging time. Our second speaker, Dr. Lena Mattel, is the Chief Division of Women's Mental Health at Brigham and Women's Hospital. Tonight, she will focus on perinatal mood and anxiety disorders and postpartum depression. Dr. Lena Mattel will begin our evening. Dr. Mattel?
Thank you all so much. I'm just going to share my slides. So as Veronica mentioned, I am Lena Mattel. I am a psychiatrist and addiction medicine specialist based at the Brigham and Women's Hospital. I specialize in mental health conditions during and after pregnancy. And in my two major professional roles, I serve as the chief of the Division of Women's Mental Health at the Brigham and Women's Hospital, as well as the Associate Vice Chair for Diversity, Equity, and Inclusion there. And then also I'm the Medical Director for Equity, Substance Use Disorders, and Community Partnerships at MCPAP for Moms. I really look forward to speaking with all of you and hearing your questions. So I'll hope to just kind of do a brief overview about what we're talking about when we're talking about perinatal mental health. So I'll go a little bit into just generally the impact of mental health in pregnancy, a little more specifically on perinatal depression, anxiety, and bipolar disorder, and then talk a little bit about how treatment is thought about in my world as a psychiatrist and how I work with amazing therapists, including John Carr, who'll be speaking after me, and then a tiny little bit about what MCPAP for Moms does as a resource in the community to support providers who are seeking some capacity building around working with individuals with perinatal mental health conditions. So most importantly, I think I always like to just sort of start with talking about just how pervasive perinatal mental health conditions are. And the most common one, perinatal depression, is the most common complication of pregnancy, affecting 1 in 7 birthing individuals. Now, when we think about mental health, though, there is a really broad impact. And it's important to think about how maternal mental health and perinatal mental health affect the birthing individual, the child, and the whole family system. Individuals with mental health conditions can have a harder time engaging in medical care, attending prenatal care appointments and other medical care appointments. Mental health conditions can increase in risk for smoking and substance use. These conditions can impact obstetric risk, like increasing risk for preeclampsia, preterm delivery, lower birth weight, NICU admissions. As we think about pregnancy advancing and the birth, lactation challenges can be impacted bonding issues, partner relationships, most catastrophically, suicide. Maternal suicide is an important and preventable risk. Cognitive delays, motor issues, growth issues, behavioral problems, mental health disorders for the child. And these are just sort of the broad brushstrokes about the wide impact that maternal mental health can have. I alluded to this a moment ago, but mental health conditions are also a leading cause of pregnancy-related mortality. Mental health conditions where a maternal mortality review committee, which is a sort of a CDC-funded mechanism that nearly every state has. In one study of 14 different states, MMRCs, mental health conditions were defined as among the top causes of pregnancy-related death, the majority of which are considered preventable. And when we sort of drill down more specifically to depression, which is what is, again, the most common of the mental health conditions we'll talk about today, perinatal depression is both underdiagnosed and undertreated. And so that really, it can seem like a bit of a sort of doom and gloom kind of approach, but I like to think of it a little bit as an opportunity to do better, an opportunity to be more engaged. And if you've noticed, I've been talking a lot about perinatal depression as opposed to simply postpartum depression, because 2/3 of the depression we see identified in the postpartum period actually has its origins before the postpartum period. So meaning before pregnancy even, or during the pregnancy. And when we talk about just postpartum depression, or think about only trying to identify these needs after the baby is born, we're really missing an opportunity to intervene earlier. And when we have the ability to do so, when we are thinking about mental health, even prior to attempting to conceive, we really want to think about preconception planning. Individuals who have any kind of condition and want to go into a pregnancy in a planful way to optimize health and well-being for both the birthing individual and the fetus and the pregnancy and the family, really can undergo what we call preconception planning. So that can mean a conversation with a treater who is a specialist in the condition that's being treated, or with an obstetrician who can advise about pregnancy planning. And also keeping in mind that the process of becoming pregnant, the journey to conception, can be stressful in and of itself. It can sometimes involve challenges, it can involve losses, it can involve fertility treatments. And so all of these things introduce both biological and psychological stressors. And we know that psychotherapy is an evidence-based treatment for depression and anxiety, and psychotherapy is safe at any point along the process. And so it's something to think about implementing as early as possible, even before a pregnancy occurs. If somebody already has a known psychiatric condition or a mental health need, and they're already on a medication, this is an opportunity to sort of streamline and plan the medication regimen, implement supports and psychotherapy, talk with family about what to look for. And I think we'll talk more about that as we go on this evening, and really think about this preconception time as critical. And also, it's really important to remind ourselves that not every pregnancy ends the same way. Sometimes pregnancies can end in loss, and that can be a significant impact on mental health too. Depressive symptoms, trauma-related symptoms, sleep challenges, impact on the whole family system again. And then also an ongoing impact on subsequent pregnancies. And so we need to think about where grief and complicated bereavement can come in and impact mental health as well. When I'm talking about mental health concerns, we'll focus the majority of our conversation around depression, but really there's a whole spectrum of mental health concerns for perinatal individuals, ranging from depression to anxiety to obsessive compulsive disorder to post-traumatic stress disorder, PTSD, bipolar disorder, psychosis. There's a real wide spectrum. And this is not an inclusive list, but really sort of broad brushstrokes around domains of types of illness. But when we're talking about perinatal mental health, we're often talking about depression. And having a prior history of depression is the number one risk factor for perinatal depression. A history of any kind of condition like depression, anxiety, trauma, or any other mood disorder, trauma-related disorder, or mood disorder also represents a risk factor for perinatal depression, as well as worsening of those conditions during the course of pregnancy and postpartum. But there are also other reproductive-related risk factors that are really important to be aware of. An individual who has a personal history of a postpartum depressive episode or a perinatal depressive episode is considered to be at higher risk to have a recurrence of that kind of an episode during or after birth, during pregnancy or after birth. Having a family history and a first-degree relative of any kind of postpartum depression or other mood episode, having a history of mood changes related to hormonal changes, which is a really sometimes an underappreciated risk factor. So somebody who has significant mood changes with their menstrual cycle, or when they've taken hormones as medications, for example, through a contraceptive pill or other form of hormonal contraception, or for treatment of fertility challenges, those kinds of treatments with hormones can cause fluctuations, as well as just the natural occurring fluctuation of the menstrual cycle. And if an individual experiences emotional symptoms concurrent with that fluctuation, that's a really important risk factor that can be useful to think about as a higher risk for perinatal depression. There are other sort of more general risk factors not linked to reproductive related time frames, the younger age, a perfectionistic personality, a history of trauma or intimate partner violence, psychosocial stress, chronic medical condition, and exposure to racism are all risk factors for increased risk for perinatal depression. Now, some of you may have heard of this concept of baby blues or postpartum blues, and how does that differ from depression? Baby blues or postpartum blues are really a very common occurrence that I am loath to call an illness at all. This occurs at such a high rate, about 75 to 90% of individuals who are in the sort of birth time frame. It occurs in the first 2 weeks immediately after birth. It's associated with significant mood reactivity, sort of ups and downs or lability, high emotionality. So that this is the sort of quick to tears. Sometimes it's happy tears, sometimes it's sad tears. Sometimes people say, I don't know why I'm even crying. But when you ask that person, that sort of net sum total of all the emotions that may be experienced at a time is usually not a depressed mood, but in fact, perhaps even a positive or happy mood. On the flip side, when we're really more concerned about a clinical condition like depression, the onset can still be within those first 2 weeks, but lasts longer than 2 weeks, is accompanied by thoughts of guilt, low self-worth, sometimes suicidal thoughts, sometimes lack of motivation that is impacting functioning. So then we become more worried about depression, especially when those cognitions, those thoughts are coming into play. Now, when we talk about depression, it's really important to know that depression is a state of mood that can be part of a more common, what we call unipolar depressive condition. That's sort of the depression we colloquially refer to as depression. But depression is also a feature of a more significant condition that's a little bit harder to diagnose, called bipolar disorder. So when individuals have depressive symptoms at any point in life, but especially in the postpartum period, we want to make sure that there's an evaluation to rule out whether it could be part of a condition that has more features like bipolar disorder, partly because treatment with medications that would only treat depression could be actually really worsening outcomes for individuals with bipolar disorder. And one of the reasons that we talk so much about bipolar disorder and worry about it is because in the postpartum period, bipolar disorder history or a propensity towards bipolar disorder can really increase the risk of postpartum psychosis. Now, this is an overall rare condition, but a large proportion of cases, about 70% of cases, happen in individuals who ultimately become diagnosed with bipolar disorder. It has a really rapid onset in the immediate postpartum period and can be a psychiatric emergency because it is associated with a high rate of harm to the infant and a high rate of suicide. And so this is why we consider this a psychiatric emergency. And happy to talk more and answer more questions about it as we go on, but I don't want to scare folks, but this is certainly one of those things that's important to acknowledge and be explicit about. Now, sort of transitioning away from mood disorders to anxiety disorders, anxiety really can present in a variety of different ways. And in behavioral health, we often talk about these different sort of domains of anxiety. Panic disorder that's associated with panic attacks, where the anxiety kind of comes in these episodic peaks and then diminishes again. Social anxiety, where the anxiety and worry is associated with specifically social challenges or social settings or social tasks. Generalized anxiety disorder, as you might imagine, is really generalized in many domains. And PTSD, or post-traumatic stress disorder, is sort of linked to more trauma exposure. So this is sort of a general schematic for thinking about how anxiety, that we use as a very broad term, can then be sort of drilled down into and characterized a little bit differently. Generalized anxiety is also something that can really be experienced in a variety of ways. So sometimes it can be the anxiety and worry that we speak about, but then sometimes it can be seen in our physical behaviors like restlessness, fidgeting. Sometimes it can be felt in our physical body, fatigue, aches, and generalized sort of non-specific soreness or tension, impaired concentration, irritability, difficulty sleeping. So it can be really pervasive, and it's really helpful to think about as sort of not one thing, but really kind of the experience, that a subjective experience. Trauma-related disorders often have anxiety as a component, but really have kind of a much broader impact on our threat detection and response system. And so they can have these disorders can have intrusion symptoms where people can experience flashbacks or nightmares, hyperarousal, or sort of being on edge, avoidance of triggers, negative self-appraisal or mood. Again, really pervasive, and with a sort of worry that's at its core kind of feature, but in this really different way. Now, whenever we're talking about mental health conditions, there's a natural question about how do we think about risk of harm to baby. I mentioned that with postpartum psychosis, for example, there's a higher risk, but what do we do with this question about thoughts? Now, thoughts of risk of harm to baby, especially in the postpartum period, are actually quite common in many conditions. Obsessive compulsive disorder, anxiety, and depression all can have thoughts that can be associated with sort of these conditions that might be characterized something like, oh, what if I'm so worried, I'm so nervous, am I going to be a good enough parent? What if I accidentally do, and then fill in the blank with all numerous worries that one might have. I really hope that doesn't happen. Oh my gosh, what if that happens? Maybe I shouldn't hold the baby right now. Maybe somebody else should take care of the baby. I really want to be better at this. So this kind of sort of spin cycle around potential risk of harm to baby. And a lot of times what my patients will say is, it's not like I would ever want to do that. Why am I thinking like that? That's just so outside of what I would ever want to do. And that kind of intrusive nature, that disturbing kind of feeling of like, where is this even coming from? That is actually a protective feature of thoughts like that. That is so common. I see it so often, and I'm actually really reassured when I hear people say, oh, that just doesn't feel like anything I would ever want to do, and I can't believe I'm thinking that. But I also want to be really reassuring and say, like, this is something I hear a lot, and it happens so commonly, and I'm really glad you told me about this. On the other hand, with postpartum psychosis, when somebody has lost touch with reality, this distorted sense of reality can create a different sort of higher risk type of cognition. And so that's really the way that we as psychiatrists think about distinguishing these different kinds of thoughts. So if we're going to transition a bit to thinking about treatment, I always like to sort of say, how we talk about it can really help as providers, how I, as a provider and a provider who coaches other providers to talk about treatment, is a lot of it isn't really thinking about allaying misconceptions. I have patients come all the time into my office and say, Dr. Mattel, of course, like I'm pregnant. I can't take anything during pregnancy. And I say, well, I wouldn't have a job if that wasn't an option. And so we talk about how there are, in fact, effective options for treatment of mental health needs during pregnancy and breastfeeding. Sometimes people just really don't even know that there are treatments, and not all treatments involve medication, but there are medication treatments too. That depression is really common during pregnancy and the postpartum period. Sometimes people feel like they are they're so much the only one. I think the discourse over the past few years has really enhanced our understanding of the pervasiveness of mental health needs, but and we're hearing much more from in the public space about how common seeking treatment can be, but still there's I think a misconception that during pregnancy, this is supposed to be a time when one is happy and only happy. And we all know that is a real misconception now. Patients need to take medications for all sorts of things. I often talk about how we are sort of in our society and within families, there can be a different conversation about it, but that mental health can sometimes be treated as a different kind of health that warrants a different threshold around which we might seek treatment. And perhaps we should change that and think about mental health as part and parcel of all of our health. And would we have that same hesitation to take an inhaler or a diabetes medication or something else that was important for our health during pregnancy? And then the last piece of this is that we often talk about in perinatal mental health that there's no risk-free decision. If somebody has a health condition during pregnancy, we have to always think about what is the risk of the treatment for that condition, but also what is the risk of not treating the condition, and the condition itself carries risk. And so, just as I told you at the beginning, untreated mental health needs can have wide and pervasive impacts on the pregnancy, on the birthing individual, on the child, on the family. Psychotherapy is a first-line treatment for mild mental health conditions. There is cognitive behavioral therapy, interpersonal psychotherapy, group, couples, family therapy, all these different types of therapy that have good evidence for efficacy in pregnant individuals and in postpartum. But also, it's really important to acknowledge that other wellness interventions have good evidence too. Social engagement, meaning new parent groups, one-to-one social support, personal engagement, meaning self-care, mindfulness, physical engagement, meaning exercise, stretching, hydration, nutrition. All of these things have great evidence for decreasing risk for mental health conditions and for decreasing the impact. We at MCPAT for Moms developed this handout at the beginning of the COVID pandemic to sort of walk through a self-care plan. It's freely available, and I can send this along in the email that'll go out after this event. When we're talking with folks, it's really important to think about balancing, again, this kind of risk-benefit discussion, thinking about the risks and benefits of the treatment alongside the risks and benefits of not treating and of the condition itself. Some of the principles I use and we use in perinatal mental health are really around picking a medication that has worked before. So we're not thinking about doing trial and error when somebody is pregnant or if they're lactating and feeding their baby milk. We want to think about using the lowest effective dose. I can't tell you how many times a week somebody will say, but what is the dose in pregnancy, Dr. Mattel? And I'll say, it's the dose that's going to work, because there is no point in taking a dose that's too low and isn't working. And then you have both the medication on board and the symptoms that could be having a negative impact too. We really try to minimize switching medications. If anybody's ever experienced sort of mental health treatment, sometimes there can be a period of trial around medications. We really try to limit that and do as little switching as possible to minimize the total exposures. We want to use the fewest number of medications possible. So if it's possible to have a treatment regimen that has just one medication, that's ideal. But if we need to use more than one, we just want to use the fewest number. pregnancy itself can change the body's metabolism a bit. And so it's really important actually to increase doses as pregnancy advances because of those physical changes. And we really want to encourage people not to abruptly stop medication during pregnancy, prior to delivery, even after delivery, but especially there used to be a practice where people might take a medication during pregnancy, but then would abruptly stop it before delivery. And really what that does is increase the risk for the birthing individual to have a relapse of symptoms. In the interest of time, I'm not going to go through every study and talk about the specifics, but suffice it to say that antidepressants, which are the most common mental health medication and that we use in medicine, frankly, are really low risk in pregnancy. There's a small absolute risk for birth defects, very tiny, very small elevation in risk as compared to the sort of spontaneous risk of birth defects. There is a very low risk condition that can happen where there are transient neonatal symptoms that can happen immediately after delivery if the neonate's been exposed to antidepressants in utero. We can talk a little more about that. It's called neonatal adaptation syndrome. There's a tiny increased risk in persistent pulmonary hypertension, which is significantly outweighed by the risks of untreated depression. Both untreated depression and medications have a small increased risk in shorter gestation and lower birth weight, but actually very minimally impactful. And they're really, the studies to date do not suggest long-term neurobehavioral impacts on kids who've been exposed to antidepressants. Also important to note that the data really support breastfeeding as an option for individuals taking medications for mental health concerns. Antidepressants and most other psychiatric medications are considered low risk during breastfeeding. There are a few scenarios where we might have a different discussion about it, and that's really kind of an individual decision between a birthing and lactating individual and their providers. MCPAP for Moms, which is a really innovative and first of its kind program in the country, but now been replicated 20 times over across the country, is a perinatal psychiatric consultation service. So providers who are working with perinatal individuals can call us and get education, one-to-one consultation about patients, and resource referral for patients as well. And so individuals anybody who is worried about somebody with a perinatal mental health condition can suggest that their provider call MCPAP for Moms on their behalf. This is the information about it. It'll come to all of you after tonight as well. We provide all kinds of resources. Our website has lots of resources that are available right now. We have toolkits for providers. We have information for birthing individuals and families. And we really do focus broadly on mental health as defined by mental health and substance use conditions. And so thank you all for your attention, and thank you for the invitation to Newton-Wellesley Hospital, and I'll stay on after for questions.
Thank you, Dr. Mattel. That was incredibly informative, and I'm sure we all really got a lot out of that. We're now going to move our conversation to John Carr. John?
Good evening. Thank you. I am so delighted and honored to be here. And before I get started, I'd like to thank the Maternity Services Council of Newton-Wellesley Hospital for inviting me to speak with you tonight. I think it's so great that you've invited a man's voice into this discussion. It wasn't that long ago that men were not invited or expected to be in the birthing room. So I feel honored and excited to share my perspective. It's important that all members of the mom support system be heard. I also want to thank my co-presenter, Dr. Lena Mattal, and a real honor and pleasure to share this screen with you. And thanks to all of you for signing up. As we all know, this is an important topic, how best to support the new mom in your life that needs more and more attention, awareness, and action. Luckily, times have changed or are changing, and the father's role is no longer limited to provider and protector. Fathers are regularly present at the birth more than ever and sharing in childcare duties more than ever. My hope today is to share a bit about how excited I get when a new dad joins a support group that I'm running or reaches out for help. My main objective is to share 4 main tips and, along with it, resources on how best to support the new mom in your life, while also making sure that you, as the support person, are getting support yourself. I offer these tips and resources based on my clinical experience of 20 years, the deeply profound volunteer work in running a monthly dad's support group through Postpartum Support International for the past 3 years. And I also share out of my own experience of being a husband and father to 3 children. I hope some of what I share can be applied to anyone in the position of support person, female partners, trans dads, father figures, grandparents, adoptive dads, dual dad couples, biological, non-biological, stepfathers, and sperm donors. For the purposes of this talk, I will fluctuate between using the term father, dad, support person, and partner because that is the population I know best. In my practice, I primarily treat hetero cisgendered men, which is also what I am, so I acknowledge that my perspective is limited. That said, I am open to questions, feedback, and different perspectives, which we'll have time at the end for. Just a little bit more about me and how I got into this work. A picture might help you understand a few things. This is my family that I was born into. And what you can see and maybe assume here is that I am the youngest of 9 children. I'm being held by my father on the far left. I grew up in I'm almost as white as my brother's t-shirt, in a Catholic middle-class family outside of New York City. I have 5 sisters and 3 brothers. My father was 37 and my mother was 38 in this picture. My mother was essentially pregnant for 12 years. What you can't see is that my mother was anesthetized for 9 of her births, all 9. And my father was not physically allowed to be present in the birthing room for any of them. My mother suffered from postpartum depression and anxiety and developed severe phobias around driving and a long-standing dependence on alcohol. She did an amazing job and needed a lot of support. My dad did his best and was limited in his ability to be physically and emotionally present. He eventually had an affair and developed a dependence on work. And they ultimately divorced after 33 years of marriage. Suffice it to say, there were many complicated emotional dynamics in my family that influenced my decision to help fathers become more physically and emotionally present. It's in that work and in my work with fathers that I have heard these things. It's hard to accept my wife's in pain without trying to fix it. My wife has changed. I don't know who she is anymore. My partner doesn't trust me with the baby yet. She supervises or critiques everything I do. I don't want to parent the same way that I was parented. I want to do it more intentionally. And I wish someone told me how hard this was going to be. I wish I was better at dealing with my anger and frustration. And one of my favorites that I didn't have room to include, but I hear regularly, is how men say this: I have nowhere else to talk about this. And it's so good to know that I am not alone. It's helpful to be in a non-judgmental space. Before I get into my 4 tips or suggestions on how to be a supportive partner, I have 2 reminders. One, that being a mom and being a support person is really, really hard. And yes, while there may be moments of joy, there will also be moments of great frustration, despair, and loss. It's a major life adjustment that impacts hormones, sleep, sex, work, mood, how you think, how you dream, what you actually do, and how you spend your time, what you eat, how you experience vacation, and even how you drive, just to name a few. The second reminder is that I'd like to say that your presence matters as a support person. You are important. Your role is important to the life of your partner, to your child, and you may not know it, but even to yourself. As we should, our society, parenting books, healthcare system, and policies tend to focus on the mother when a child is born. This is how it should be. And there is also so much more that we can do with respect to equitable and just care for all moms, especially moms who are poor and Black. These efforts need to continue. It is also true that I know a lot of dads who genuinely feel like they are not important. And I'm here to remind you that you are. There's a ton of research that supports this. You can find some of that in my resources page that I give, that you'll receive tomorrow. So here are my 4 suggestions or tips for you in this role as support person. To educate yourself, show up emotionally, to do supportive things, and get support for yourself. Let's start with educating yourself. As a disclaimer, I want to say that this is a steep and long learning curve. It's much like Heartbreak Hill. So pace yourself. It's a lot to learn. The first thing I'd like you to focus your learning on is to become a student of your partner. the birth parent. Learn what she's experiencing, what she finds supportive. Don't assume that you know what is supportive. Learn what she needs in a given moment, what her sensitivities are, her history, her trauma history, her mental health history. This could be a great opportunity for you to join individual and/or group therapy or a support group. The second is to become a student of your own needs and sensitivities and history. What's your own trauma history, your own mental health history? Again, another opportunity for you to join individual and/or group treatment. Become emotionally intelligent. This is a big thing that I work on with the dads that I see. Helping them to identify, name, validate, and express their emotions in productive, constructive ways. And to practice the skill towards themselves and towards their partners around compassion, empathy, curiosity, and patience. These are all opportunities to learn those things. I asked a dad recently in one of my groups, or I asked the whole group, if there was a class that you could take. You know, they always say there's no class, there's no school for becoming a parent, there's no manual on how to do it. So I asked this group, I said, if there was a class that you could sign up for ahead of time, what would it be? And without hesitation, many of them said a class on emotions, on how to learn how to deal with and express and identify and name emotions. He got an A in that class. Become a student of your child's developmental milestones. What's typical? What's not? And then finally, learn about postpartum depression. Did you know that 1 in 5 moms and 1 in 10 dads experience postpartum depression? Number 2, showing up emotionally. Emotionally supportive things that you can say. Now, I'd like to prepare you that your partner may not be ready to use you in this particular way. You may even be rejected for providing emotional support. The feelings that she's experiencing may be so shameful, the fear may be so big. The most important thing is that she have a safe person to connect with, and that you respectfully express your love and care. But here are some things that you can certainly try to say and see if it lands. Reassuring that your partner, that you believe in her, that she can do this. You can say, I am here. I hear you. That sounds really difficult. That's one of the most simple things to say. It's one of the most compassionate things to say. So, wow, that sounds really difficult. I am here with you. Tell me more. How can I help? Let me know if that was not helpful. Make yourself receptive, make yourself open to feedback as to whether or not the help that you thought was helpful, whether or not it was. Get feedback. Do you need a break? And the one that I used with my wife once, I mean, more than once, but there's this one particular time where I said to her after she had been breastfeeding and working, I said, "You're doing an A++ job with this." And I had no idea what kind of an impact it would have on her until she told me that it was really, really meaningful and helpful. That turned out to be a supportive thing. Do supportive things. And a little disclaimer about doing supportive things is that for some moms, it can be really hard to let go and allow you to help. Do your best to not take it personally. This is a great opportunity for you to practice patience and respectful persistence. First one I'd like to go over is to be realistic about what time you'll be home, and come home on time. And if you're going to be late, communicate. Find jobs within the house. Get really good at soothing, holding, doing diapers, laundry, dishes. If it's not direct child care, find something that you can get good at. I have a dad in one of my groups who says, I could change a diaper with my eyes closed. Do what you can to make sure your partner eats regularly throughout the day, because low blood sugar results in low mood and frustration. Go to as many doctor's appointments as possible. Let her sleep in. Take the baby for a walk. Relieve her. Free up her arms. Take regular night shifts. So you got the first half of the night if the baby gets up, and I got the second half. Or work it out. Keep her water bottle filled. Simple, practical things that are helpful. If she's open to it, rub her neck, her feet, back, shoulders, brush her hair, and make her favorite meal for breakfast. And finally, get support for yourself. The most supportive partner is one who feels supported themselves. It's very possible that if your partner is struggling with postpartum depression and/or anxiety, there's a good chance that you are as well. So find a community and build your support, your network of support. Attend a weekly dad support group through PSI. PSI is Postpartum Support International. I run a group once a month. It's free. There are support groups offered every Friday for fathers. And they're going to probably expand that. I've been doing that for 3 years, and it's just incredible. Guys from all over the world join this. We have it on average about 13 dads in the group per week. Call the PSI Postpartum Support International's helpline at 1-800-944-4773 to find a therapist in your area. And I have to tell you, I've heard from guys in my group who have found therapists through that service in their area. Find people to talk honestly with. So connected to that is to fight the temptation to say that everything's great when it's really not. And then try not to solve, fix, or change things too quickly, and work towards being really with your partner. And finally, I'd like to close with just a quote. Surround yourself with people who don't just ask how you are doing. Surround yourself with people who make an effort to make sure they are part of the reason you are doing so well. Thank you so much.
Thank you, John. That was wonderful and so informative. I wanted to just ask you a few things. You mentioned the dad support group and it being an international thing. The thing that you run every Friday, is that based on a Zoom meeting or is that in person?
It's a Zoom meeting that you get through PSI. You register through PSI, the Postpartum Support International, and that's on my list of resources.
Okay, great.
Yep.
Thanks. And what are some specific ways a father can get support in becoming more supportive to his partner?
Well, I kind of addressed that already, but I think if I had to, I think one of the things that I have found really helpful for dads is talking with other dads on how, like, kind of literally like swapping stories. How did you do it? Realizing that they're not alone and that there are other people who are grappling with this. I think I have this experience in my practice and then just in my life where I've noticed that fathers tend to father in isolation and moms tend to mother in community. And so whenever a father kind of reaches out and for connection and the desire to kind of realize that they're not alone, it's just incredible how that can help them become more supportive. They're practicing the skill of getting support themselves. I think that helps them become more supportive. That makes sense.
That does make sense. And we've spoken a lot about the mom, the father, the partner. And this is a question for maybe both of you to address. How can a grandparent kind of help or get involved without seeming intrusive? How can they take some of the warning signs and take action? What's the best way for them to kind of step in and help?
Leanna, do you want to go?
Sure. So one of the things that I tell my patients is that part of what you need the kind of help that's going to be the person you can ask to put a load of laundry in. That it's really sometimes the instrumental help, the sort of tasks that can take away from building the relationships and getting the rest and recovery that the caregiver or caregivers need. And so in a lot of ways, it can be hard because there's a lot of well-meaning folks, grandparents, or anybody really, any visitor who wants to come and meet the baby and hold the baby and oh, why don't you go take a rest while I'm holding the baby? The reality is that's actually pretty hard to do as especially early in the postpartum period when still trying to kind of bond and get all of those relationships. But what families and sort of the whole system need really is like the instrumental support, food and support and a quick hello and then go, or whatever is needed. Nighttime, when the going gets rough. That's the type of support. And it's really following people's cues and kind of dropping in and out and not kind of spending long periods of time together. Those are kind of my tips.
John, anything else to add to that?
Yeah, I would just connect it to that. This is so much easier said than done, but I think, grandparents who can be mindful that what's really happening for the family is they're trying to learn how to be a family. They're learning how to connect with each other. And so while the grandparent might have a lot more experience, especially like you mentioned, the over intrusive grandparent, the challenge for that grandparent, I suppose, is to try to remember that this family is trying to kind of like get itself, learn how to do it. And there needs to be some respect in letting them kind of make mistakes and make decisions. Those decisions are their decisions, and that's a family that's going to learn. So
Now,
it's tough.
what if though a friend, a grandparent, we're talking about people that are kind of coming in, maybe bringing a meal, doing some, not with the mom or baby 24 hours a day. If a grandparent or a friend steps in and it becomes worried about the baby's safety, the mom's mental health, what is the best thing to do for that? And how should they approach it? With the dad? Should they try something else? What's your go-to on that if they're really troubled about the baby's safety?
It's a
Well,
great
maybe I
question.
can start there.
Okay.
I think safety is one of the most important kind of basic tenets that we have to attend to first. And so I think safety has to be addressed, ideally proactively. So one of the things that I like to do with families or couples or expecting couples is have what I call a mental health care directive. So sort of have a conversation, it's kind of like an advanced directive conversation about other decisions in healthcare. What are the warning signs? What are the things that would make me worry about you? Are you, now that we're having this conversation while you're well, like, would it be okay if I called so-and-so, or could I have the phone number for XYZ, or kind of get some of that information and talk a little bit through the contingencies ahead of time, like when things are not in the midst of a crisis. And then I think it's really important to have a low threshold to engage healthcare support. So whether that is the OB who delivered the baby or took care of the birthing individual, the pediatrician, there are mobile crisis services for mental health support that can either come into the home or can meet people in emergency rooms and that kind of thing. So when there's a concern about either self-harm or physical safety, those are things that I sort of feel like are do not pass go. Like you have to just really alert the systems in place.
Right. That's not intrusive. That's helping. John, what do you think?
Yeah, I would just echo that. I'm actually curious, Lena, if you have a resource, a good solid resource on a particular hotline to call in a case like that, or mobile crisis. Like, is there a particular one that you would advocate for on that?
Yeah, actually, as of January 1, Massachusetts has a sort of central number called the Behavioral Health helpline, which I'll put in the chat. I'll put that information in there now. And then also Postpartum Support International has a 24/7 HRSA funded helpline that is nationwide and connects people to their state chapters of Postpartum Support International. So those are the two numbers. I'm happy to put those in the chat now while as we keep talking, and we can put, send them along to any registrants as we go too.
We're
A lot of it also, real quickly, depends on the quality of the relationship that the family, friend, grandparent, friend has with the mom and dad, assuming there's both in there. But if so much has to do with the depth and quality of that, because there could be a situation where the mom would feel like that's a parent taking over and that's too much, but there also could be a mom who experiences that as care and loving. So I need help.
It's a fine line, right? It's a fine line, but I think you have to, correct me if I'm wrong, you're saying trust your instincts, and if somebody needs help, you should reach out.
Yeah.
Okay. Our time is drawing to a close here. But I want to really thank Dr. Mattel and John Carr. This was so informative and valuable. I hope everyone enjoyed this webinar. I'd like to give special thanks to the Newton-Wellesley Hospital Maternity Council, which is part of the Newton-Wellesley Hospital Community Collaborative, for their financial support in our program tonight as they enable tonight's program to happen. All who attended our event tonight will receive an email with a list of helpful resources as a supplement to our webinar. And in addition, you can find it on YouTube under the Newton-Wellesley Hospital Community Collaborative page. We did have one more question that talks about accessibility for mental health and if you have Medicaid. So if either of you have a resource that could help somebody with differing insurance. And you could add that to the resources. That would really be appreciated, so someone can be guided towards the right provider in that case. Thank you all very much. I hope you have a good night, and take care. Bye now.
Thank you.